6 and stream out.
Test, test. 1, 2, 3. Test, test. 1, 2, 3.
Testing 1 1. Testing. Testing 1 2. Testing. Testing 1 3. Testing. Testing 1 4. Testing. Testing 1 5. Testing. Testing DT. Testing. Testing DT. Testing. Testing DT.
Push it on.
Test. Test. Testing 2 1. Testing. Testing 2 3. Testing. Testing 2 3. Testing. Testing 2 2. Testing. Testing 2 4. Testing.
Good morning, everybody. The Finance Committee will come to order. Our committee meeting isn't bothering your conversation, is it, Mr. Powell? Welcome, everybody. Good morning. Any citizens wishing to address the committee? None. We'll move to item 3, which is approval of the minutes from the December 12th meeting. Entertain a motion. Motion by Dr. Weber, second by Mr. Nguyen. All in favor, please say aye. Opposed? Motion passes. Item 4, CFO report. Ms. Clark.
Good morning. This morning, I wanted to spend a couple of minutes going over the results of our recent bond ratings. If you recall, we have dual bond ratings both from Standard & Poor's and Moody's. With the small amount of debt that we have outstanding, they typically request a call or an update every 12 to 18 months. And we just completed those in late December and 1st of January. So I was able to send you guys out the final rating credit report for both of those. And they are on your portal if you have not had a chance to check those out. It's a fairly easy read. A lot of it is technical. But the good news is that both ratings were reaffirmed. S&P has, for the last 2 years, had us at a AA stable. And Moody's reaffirmed a AA3 with a negative outlook. They attached that negative outlook last year because of the potential debt issue and our master facility program that got approved by the voters. And with that, they feel like any additional debt that comes on would result likely in a downgrade to an A1 credit. We would be a very strong A1 credit, but just to let the committee know, as well as kind of managing expectations for the future, that was a strong message both in the written report as well as the verbal communication.
Okay.
So,
As they say, Moody is Moody.
sometimes, yes, they're a more aggressive rating. We did have really good conversations, and I do want to tell you that I feel like we have open communications with both of the analysts that lead the teams for both Moody's and S&P. So it's always a good conversation. As we do prepare for any kind of a debt issuance, they will come out for a face-to-face and reassess our credit, as well as kind of layer on what that additional debt, and when the projects are defined, we would have that prior to the debt issuance. They would want financial projections and recalculation of the ratios. So we are moving forward with all of the progress with the bond issuance. So I think that'll be an easy transition. So if I can go ahead and move forward into we have two, because of the way that the holidays land, we've never presented November financials. I'm not going to spend much time on those today because they are cumulative for December, so I'm going to skip over all of the graphs and just look at the actual performance. Let me get you the page number. That is going to be on page 19 of your portal. If you recall, we struggled with some payer mix issues in October. I continue to stress that payer mix in the budget, it remains flat, but it fluctuates greatly from month to month, and it has an enormous impact on our financial results. In the last quarter of 19, we had a couple of poor payer mix months there at the end. We had another one in October, and the October results left us about $2.8 million behind our plan financially, our income from operations. November, we had a pickup, a positive payer mix, and you'll see it again in December. So again, it's an averaging out, and you'll see here the actual results. We were able to pick up $1 million in November. Most of that is resulting from a volume increase. Our admits were about 9% over, and our outpatient revenue was about 9% over. So it was a very busy month with a positive payer mix. So to support that, we had some additional salaries, and we ended up about $1 million ahead. That leaves us with about a $1.8 million gap, and our income from operations is budgeted. Good news is when we get to December, we're almost back on track. So very quickly for a claim, we'll go over all of the colorful graphs in December. For a claim, they fell short of their plan by about $600,000. For November, encounters were low. We also had that coupled with an Epic upgrade, which kind of slows down the providers as they get used to some of those new requirements and new screens. We also had an increase in some call coverage. It was also an incentive payment month, and although we do accrue those, it was one of the larger months, so that hit the expenses slightly. So year-to-date, a claim was still pretty much just ahead of their operating plan. And if there's no questions, I'm going to go ahead and go right on into December. So December was another busy month from admissions. They were up about 5%. You can see that we've had an increase of about 7% in admissions from budget year to date for the first 3 months. The other thing I'd like to point out is we had a very high case mix index for the month. If you recall, most of our plans, an admission is paid on a base rate, and then the case mix is a multiplier that as the acuity or the intensity and sickness of the patient occurs and it's documented and treated, we will get the base rate times the CMI. That's really simplistic, but that's the importance of the case mix. So when I get to the revenue in December, you're going to notice that we had a positive payer mix, but the CMI was incredibly high. A lot of it was coming from our surgical areas in orthopedics, pulmonology, and cardiac. So incredibly high CMI for the month. Our ER was very high as well. We had 10,500 visits for the month come through the ED. That is the second highest volume on that 3-year trend. That's about 339 patients a day. And when you couple that down here with urgent care, you can see that we were about 5% over in urgent care, or another 143 patients a day being seen there on average. And of course, they don't average perfectly. So we had some incredibly difficult volume months in the ER this month. The primary care visits were right on target. And year to date, those are about 1% ahead. So that's tracking very nicely. Our specialty clinic visits were about 9% under, but they're about 4% under for the year. So I believe we are working on some staffing in some of those clinics. So some of the other key stats that we want to look at, our inpatient and outpatient surgeries. Inpatient was a little under this month, but again, the CMI and those surgical cases were very high. So, keep erasing that. You can see that that's, even though we were under in volume, the intensity of those surgeries were more than made up for with the acuity. And the outpatient surgeries are about 8% over for the month, so busy there. Our mental health graphs are showing pretty much on budget for the month, and our patient days, as well as the PEC continues to trend pretty nicely this year. It is over our budget, but with some of the operational changes that we made, you can see that we started to do our budget back in April and May, but our actual results are fairly constant with that last quarter. So I assume that that's going to trend out for the rest of the year.
Hey, Sharon?
Yes, sir.
Why did we budget PEC visits so low compared to previous years?
So there were some operational changes that were occurring. The way that the places that they came, they now come through the main ED. We have staffed the ED very differently with some psychiatric professionals that will screen actually in the emergency department. And we really were counting on, for the budget itself, that there would be dismissals from the main ED and we would see a decrease in the PEC. What I think is happening as these mental health screenings are done more intensely, that we've identified a greater population in the ED that actually need to go to the PEC. So we had a decrease from one action, which also caused an increase. So I think we truly just under budgeted the PEC.
Okay.
And again, I think that trending will occur. It's kind of leveled out.
Okay, thank you.
Financial metrics, it's a good page. We have about 206 days available cash on hand. We're starting to see the benefit this month, next month, and in February of you paying your property taxes. County collects those and gets those within a week to us. So you'll see that nice ramp up, and then it'll start to, we'll start to utilize that cash throughout the year. If you're trying to compare it to the Moody's calculation, this is the graph you need to look at. It's kind of the same calculation, but this one this one over here excludes the JPS Future Fund because that's not available in my mind for operations. So, however, if you look at S&P and Moody's, they look at all unrestricted cash and would use the higher number. So it's closer to 260 using their calculation for comparability. They use the bigger number, yes.
So to that point, I think there's probably a message in the Moody's response, and that is that we still need to be very careful about protecting cash. We don't need to go commit significant amounts of cash to capital obligations relative to the bond program that we don't have to, because we've already seen that it potentially results in a downgrade on our bonds, which costs us an interest and everything else. So that's been a discussion over the past 3 months as to how we utilize cash relative to the bond program. This is a pretty clear message that we need to protect cash, right, Mr. Chairman?
Yes.
I wasn't gonna say that.
So S&P, again, we have a stronger rating with S&P, but that does not mean that once the debt is issued, that will not impact that rating. But we're at a AA stable. So even if it was downgraded, we would still have a AA credit with them. I do want to reiterate that Moody's was clear when that debt is issued that we will have a downgraded credit. So, cash is incredibly important. The debt to cash ratio is incredibly important. And so it's a very complex, it's a little behind the scenes, but a few years ago, they did give us some guidelines as to the weightings and the formulas that they look at, and it's a very complex process. I do want to point out that Roy will be up at the table a little bit later, but we are at an all-time low again for net AR days. We are down to 42 days, which is incredibly positive. We are not manipulating the calculation. This is a true decline in outstanding accounts receivable. We are bringing in more cash. It's not a write-off policy change. BKD verified that a couple of months ago, so there's a lot of good work going on in our rev cycle area. And he is celebrating his 1-year anniversary. So I told him this morning, it's gone down 10 days since you've been here. So I don't know that we're going to get another 10 days out of him next year, but yeah, it's a good story. Yeah. Well, you know, if we don't bill and collect, I can get pretty low, but yeah, I don't know if I can go to that model. And our FTEs per APD, just remember, this is a 3-month calculation. It's a year to date. So this is our actual number at 5.56. We actually budgeted 5.6. So it is a favorable calculation for the first 3 months. Our payer mix chart has not changed a lot. We did break out this darker blue area right here, which is Medicaid pending. Most of the time, those do get identified, and we reserve for them as if they are Medicaid with a conversion factor. But that's an important part of what we do. And 2 of the contracts that you're going to be approving, which are pretty large today, are for this part of this conversion process. So that is a population of accounts that we watch very closely. We want to make sure they get coverage and don't fall back into the self-pay arena. Our connection enrollment, we are at above 43,000, and you can see that this year is much stronger than it was 12 months ago. I do want to prepare you that we will likely see a slight decline out here again in January, because a large part of our supplemental program will have to re-enroll for some of the ACA plans. And we see that dip traditionally in January. Michelle Haynes and her team in eligibility are very aggressive about phone calls, letters, getting these folks re-enrolled so they can maintain that primary care benefit. And then for December, again, we had an incredibly strong month operationally this month. The main story, again, that I've kind of been telling you all along is up in net patient revenue. We had a very strong volume month, and then we had a very positive payer mix. The mix accounted for about $2 million. The volume accounted for about $1.2 million of that $3 million above. So we live for payer mix. It does. Our expenses were right on target overall, although we had some variability. We had some positive variance happen in our salaries. We were down a few FTEs, and our overtime utilization was down, and that makes an incredible difference for us. Health is still trending high. It's $650,000 above budget for the month, and the health accounts for most of this year-to-date overage. Now, our health plan year is set on a calendar year, not a fiscal year. So we do try to trend it, and we do try to account for that. But also remember that deductibles, there's always that year-end rush for your favorite surgery in November and December. And people tend to utilize healthcare more in November and December. So that might be a little bit of what's happening. Yes. So you don't want to miss out on the benefit of having the year closed. So we will start a new plan year in January, and we'll see if that levels out before the end of the year.
Love it when people run into head surgery. We do.
Before we leave the page, I do just want to make sure that y'all all realize that we have, the first quarter has been very positive. We're $1.8 million ahead of a $16 million operating goal. Year to date, yeah. 3 months in. Going to Acclaim, some of their statistics for the month, they were about 6% under in build encounters. Again, there are certain areas that are still being recruited for, and we can talk about that on the next page. Their net operating expense, I typically go over that. They have had some higher expenses, and it's unfavorable for the first 3 months. Now, 1 month can make a huge difference. I'm not too concerned about that at the moment, but with the volumes being down and some of the expenses being up, this ratio is not favorable year to date. But again, I think as volumes start to increase, as they've been budgeted to, we'll see that flatten back out. Yes.
I thought the volumes was up for primary, and I'm just trying to figure out what volumes they are low in, because it,
Yes, so if you look at, so here's the encounters. So if you look at primary care, it is showing that we are under in primary care. And Dorothy, one of the confusing things that we went through in July was how the medical center's budgeted encounters look, or visits, versus the encounters that are occurring in the professional side. So you can have multiple encounters for a single visit. So we count the patient coming through the door on the medical center. That's the visit. So an encounter, you can have multiple encounters for one visit. So it could be the acuity of the patient. It could be that, well, obviously, the way the math works out, it would have to be there are fewer encounters being performed.
encounters, if they do more than one, that would be the increase in the billing side, that would be more things that was done.
Correct. Correct. So we can, yes, we're on target for visits on the medical center, but we're below the encounter mark on a claim. They're seeing the same patient, they're just not performing as many encounters. And we can drill into that, and I'll try to have you a few examples next time.
Wasn't part of it just provider availability in December? I mean, people are on vacation, right?
They
You
are.
can do as many panels, but there's not as many people to serve.
Yeah, so if you look at the December volumes, again, the encounters were down by about 6%. You can see here, there was quite a bit of vacation. We do try to schedule for that, but there was more than expected. And there were vacations. Call coverage was over in salaries. We had a little overage in contract labor to cover for those vacations. And so, you know, it ended up being a negative month for a claim. Now, year-to-date, you know, at the end of November, they were about on track. So we're only 3 months into the year. But there were quite a few low volumes, higher expenses. That combination impacted the financials negatively, as well as that cost per encounter. If you look at the overall income statement, the combined, I just want to really look at, oh, that's wrong. It's harder than it looks. Not want to erase. Okay, we're going with red. If you look at what I'm circling in the red, we have an income from operations of 11.4 million over here, and then compared to a budget of 9.8. So as a system, we're still about $1.6 million ahead of our budget plan.
No one likes red on their income statement.
I know, I couldn't get the blue to go away, and I don't know that, maybe I should have done green. So, and that's the end of my prepared remarks, unless anybody has any questions on the financials.
Any questions for Sharon? We need to take item 5A and B separately and vote to accept them. So I'll entertain a motion for item 5A. Motion by Ms. DeBose, second by Mr. Powell. All in favor, please say aye. Opposed? Motion passes. Item 5B, which is the December report. Entertain a motion.
Move approval.
Motion by Ms. DeBose, second by Mr. Zimmerman. All in favor, please say aye. Opposed? Motion passes. Thank you. Rory, come on up for number 5C. Happy anniversary. Thank you. Speaking of anniversaries, I think it's the 1-year anniversary of Miss Arizola, too, to the board. Is that correct?
Is it? Wow.
Happy anniversary. We never thought you'd last this long, so we're, well, I did, but they didn't. I did, though.
I know, board longevity is pretty good here. So.
Yeah. Welcome, Rory.
Thank you.
Item 5C.
This is an important policy, and I want to take about 5 minutes and explain to you the importance of what is driving the change to this policy. As you read through it, it probably doesn't look like much of a change, but it will be. It's a potentially a really large financial pickup because of the way that the state of Texas is changing how they get their base data for the calculation of some of our federal funding like UC and DISH, and the way they calculate our caps. So I'm gonna try not to get too technical today, but there's also a term in here that is presumptive charity. Historically, at JPS, we have identified our charity patients as those that have been approved for connection. But there's a legal definition of charity that defines the inability to pay as more than what we do for our connection program. So if you remember our pie chart, there is a large amount of self-pay that come through. So we have, gosh, I can't read it. Okay, the self-pay is here. This is the population that I'm talking about today. It is not the connection. That's already done. Those patients are set aside. So what I'm talking about for this policy, our self-pay, when we're evaluating federal poverty guidelines here, we're really talking about, you know, the 15, 16% that's sitting up there in self-pay right now. We also have a large population that qualify for charity that is non-connection patients, the purple part of that pie. Currently, we are granting those self-pay patients an immediate 40% discount at the time of billing. They don't call in and request it. Their bill is discounted by 40 and we send the bill out. Presumptive charity will allow us to partner with a third party that is like a credit scoring agency that goes out and gets public information about your zip code, where you live. They'll look at your credit score and other public areas of information, and they will presume that you would qualify under the state definition of charity. For those patients that are scored at 400% of poverty or below, we will actually be granting them an 80% discount at the time of billing. And that will get us somewhere close to what we would collect from Medicare. The 40% represents what we would collect from a commercial insurer. So it will be a benefit for our patient accounting team. It's a benefit directly for those patients that are impacted. The ones that score over 400% of FPL will still receive the 40% discount. But this also allows us, from my bigger picture, to account better for the true charity costs that we are collecting. It's mainly a reporting. We're not gonna lose collection dollars to any magnitude. It's actually just defining which category they go into on the backside. It also allows me to pick up and report all of that on a document called the S10 within our Medicare reporting, Medicare and Medicaid S10, which will allow us to maximize our cap for UC and DISH. So there's a lot of pieces to this policy. I wanted to explain to you the importance of that and see if you had any questions.
Significant. I mean, it is a huge benefit to patients. The whole idea of presumptive charity, to me, that was a new word, a new term when you told me about it the other day. I think it's really significant, and I'm really glad that we're able to do this. This has a huge benefit to our patients and to our customers. But then on the UC side, right, there's a benefit later on.
Well, and we will lose potentially, Rory spent the better part of nine or 10 months since he's been here working through the logistics of what we're doing here. It'll be a clean cutover, but we could potentially lose some self-pay collections. There are self-pay patients who will continue to pay on their bill as they can, even though they would be deemed, below 400% of FPL. But there's a much larger potential pickup, which would broaden our share of the pie in that very complex UC calculation that HHSC performs each year.
So the criteria could be what zip code you live in. I mean, there's certain criteria they apply to.
Demographics, zip code, they're able to look at your credit rating, how much debt you have, and they're able to assess a score that puts you in that. They actually return a federal poverty guideline score, and so we're able to see, for example, 100% or 200%. So they actually return that through their algorithm.
And that's before they actually get actual income data. I mean, that's just presuming based on those demographics that you're presumed charity. Is there a way to go back later and say, all right, Mr. Bass moved to that part of the city and decided to come here? I mean, we'll figure out. All right, he does have the
one of
charity.
One of the protections we're putting in is once you get a score, for example, in January, you'll be rescored each month. So if your demographics change, certain things change that put you in a different bracket, make you more able to pay, or your propensity to pay goes up, then we're actually going to know that, and we'll actually make that adjustment. If you win the lottery, for example.
Correct. Right.
No, I was just, I understand what you've said. Will this impact how much money we have to send to the federal government to be able to, every year I don't know if it's every year, but.
The IGT
Yeah,
payment.
IGT. Will this impact the IGT overall?
So I would say hopefully our intergovernmental transfer allowed by HHSC would go up based on our ability to draw down, because if we push up IGT dollars, we get, we might push up $1, we might get $1.50 back. So that's how the net UC pickup works that we talk about pretty much semi-annually when we're able to do that.
And all I'm thinking about is one other hospital district decide they're not gonna pay IGT. And remember, we went through that scenario, and it was just a question that I was wondering overall, would we end up paying more there eventually?
So I don't think that that is a concern from a detrimental side. The three big state programs, again, it's pretty complex. DISH is statewide, so if someone does an IGT for DISH, then we're all proportionately decreased in the pool. UC, we are actually able to IGT for ourselves and then IGT for others. And then for DISRIP, it's more on a regional basis, which we do that. So for UC, I don't see that we're at a big part of the risk. This is really, I've described to you guys before, all of, for UC, we have one huge pool. It gets put into 5 buckets: large public, small publics, private hospitals, physicians, and ambulatory. Then those buckets are made into a pie, and we all put our cost information in and our below cost reimbursement, and that ends up defining what piece of the pie we get out of the large public. So this will start to impact how much the large publics get. So the large publics conceptually will get a larger pie out of that first cut, and then we'll get our proportional share after that.
I just want to, Roy,
Go ahead.
I just want to commend Sharon what you're doing, and Roy, I became a little bit involved in this with the loss of the CMS lawsuit. I know there's about $3 billion sitting down in Austin. I have someone actually kind of close to Health and Human Services Committee. But I think what you're doing is phenomenal, because I think there's a substantial, I think we're not reclassifying, I think Steve, you said it right. Number one thing is not about the money, it's about taking care of the patients. We're taking care of those patients.
We are.
We're not trying to label anyone anything. This is going to be done by a third-party deal. So this presumptive charity, I would think, is one of the major public hospitals in this state. With the funds that are sitting down there, and with the documentation that hopefully we can provide, there, especially that first cut, there should be a substantial, and I'm not qualified that, but there's a lot of money sitting down there. So I commend where you're going, because I think it's going to be I hate to use the word windfall. We're handling the patients. It's not a give me. But all I'm saying is I think you're doing the right thing, because I think we will see a substantial, if anybody's dealing with the uninsured, it is this hospital district. And hopefully we'll receive a substantial. So I commend where you're going, because I think we're getting out ahead of that. And I know they started this about last August or September with the national lawsuit that CMS lost. Those dollars are escrowed down there, and I think what you're doing is great, because I think whoever can get in there and prove up that larger percentage, especially being a county hospital, we should get a substantial amount of those dollars. So
there's
I'll give the finance committee and the chairman, but I think you're headed down the right road.
the new S10
Right.
calculation will be effective for this state fiscal year.
Right.
And during the budget presentation, we talked about the new methodology that the state was moving to. We've not budgeted for additional dollars. It's a complex formula. I've only seen one projection from the state, and that was almost a year ago, of what the impact would be. So I'm just trying to put us in the place to correctly report the true charity care that we're doing. And this policy will allow us to go back and retroactively grade from 10-1.
Yeah, which hopefully will be, again, and I remember you and Robert mentioned that back when we approved the budget last August, that was an unknown piece of the formula. And hopefully it turns out to be substantial. The district certainly could utilize the funds irregardless of which budget year it falls in. But I think you're doing the right thing by being able to present to the state that, hey, here are the true numbers. And if that's the new legal definition of presumptive charity, I think we're certainly providing that service. So
There'll be a lot of changes. In prior years, our UC caps were calculated on a below-cost Medicaid plus our self-pay charity reporting. This year, those hospitals with large below-cost Medicaid numbers, that is not a number on the S-10. The S-10 only picks up true charity self-pay patients. So, again, it's not often where we are making changes that are positive on three fronts. This will help our back office, which is probably the minimal gain. Our patients will benefit from this directly, and it'll put us in a true position for the reporting on the S-10.
Good.
Will it, Sharon, will it reduce potentially, because of the definitive changes, the amounts that charity care and the privates are able to pull down from uncompensated care?
So the original, the big gaps are actually the children's hospitals, because they're at least half Medicaid and they have such a small self-pay balance. Kids qualify for coverage. So they have just a very small amount of true charity. What they were claiming on their caps, the largest part of their caps was the below-cost Medicaid reimbursement. So it's massive change, and that's part of the complexity of the conversations as we talk about URIP and DISRIP, and there's winners and losers. It's a zero-sum game as they distribute these big pools of monies, and people learn how to benefit from the formulas over time. So I think this first year is going to be not surprising, but interesting how it's going to end up, and then the next 4 or 5 years will further define how the formulas are reacted to.
I think that's a very good flip.
There's going to be a lot of pushback from the legislature.
Chad, that's why I commend us where we're going. I think once they see the amount of dollars that's sitting down there and how it gets allocated based upon this new legal terminology, I think, I'm not saying they should be shocked, but I think once the big publics get that share, which they should deserve under the formula, I think you're right. The other systems are going to say, well, wait a minute. Y'all used to pass through your IGT. Y'all are getting X, and we're only, I think you're right. I think once, this is, as Roy knows, this has been going on since about last August. I mean, they've been grinding through the process of how this is going to get done. But I think when the dollars start getting handed out, there'll be a lot of systems look at this, but that's all we care about.
Hospitals in Texas are looking at how charity gets reported through their S-10.
I bet they
So
are.
we are not alone.
It's kind of like a uniform for all hospitals now, because everybody was defining charity different. So this will make all hospitals do charity the same way. Oh, yeah, you're going to have some pushback. Oh, yeah.
Will each case be evaluated individually, or will it be lumped
It's on a patient level.
per patient?
Each month, we'll do the patient evaluation.
So that was one of my questions that I had on the per patient level side of it. One of the things you said that each month they'll be assessed for demographics, credit scoring things. What is the percentage movement in order for them to receive a higher payment?
To be billed more.
Right.
They would have to cross over the 400% of federal poverty guideline to actually move from that 20% payment to 40%, 60%. So that score will place them in a bracket. There's 2 brackets, under 400 and over 400. So and that's a significant movement when you go from, say, 200% of federal poverty guideline to over 400. That's a significant movement in their income.
Correct.
Yes.
Yeah, I just wanted to make sure, so if it's determined based on placement of living, of moving into a certain zip code and things like that, you can move into a certain zip code and still have a lower income. So all of those factors will have to
Yes.
will be played in, but I wanted to see what was the breadth and depth of the amount, the significant
Assumption,
portion.
but you could still qualify.
Correct. Outside of the presumptive process, you could still go through the connections process and qualify through that program. It doesn't exclude them from going ahead and going through that path.
Right. That's why I was asking, because those individuals are transient. They move a lot. Okay, so.
So we're actually going to evaluate at the guarantor level. So you could have multiple family members receiving services. So multiple patients could be attached to a payer, the payer or the guarantor. And so we're going to look at that guarantor and score them, and that would be done on a monthly basis for that family unit.
Any other questions for Sharon or Rory on this? Okay, I'll entertain a motion on item 5C. Motion to approve by Dr. Weber, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. Thank you, Roy. Stay put. I do want to highlight, though, that I missed that Mr. Zimmerman is also having his one-year anniversary on the board.
I refuse to accept that. I want to be an old-timer.
You'll get there.
Your compensation goes up, you get two cookies. That first year is kind of,
Yeah,
well, the first one down.
I would agree with that.
So we'll move to item 5D, and Rory, you're up again.
Yes, before you, item 5D is a professional services agreement for outside coding. From time to time at JPS, we have additional coding needs due to volume surges or due to staffing shortages. In particular, coders are in high demand, and we run a vacancy there from time to time, 2 to 3 coders. So we have to divert coding to an outside company to help us stay current with the volume and not have delays in billing. We have a company, AGS, who's had an excellent work history with us, high-quality work. We had 10 responses to the RFP. Each of those were evaluated for cost and quality. This is a 3-year re-award of this contract, roughly $500,000 in cost to JPS.
Any questions for Rory on this item? And motion by Mr. Petty, second by Mr. Zimmerman. All in favor, please say aye. Opposed? Motion passes. It's the Rory McCready Day. Item E, please.
So we'll kind of discuss item E and F in tandem. They are kind of joined together at the hip. Every 3 years, roughly, we go through a process of evaluating companies that assist us with third-party eligibility for programs such as Medicaid and those disability programs that are those really ill patients. We have an excellent team working on the connections eligibility through Michelle Haynes. This is really getting them qualified for government assistance. The current vendors in this space were Change Healthcare and MedData. JPS intentionally splits the alphabet for these companies so that we can monitor performance just to see how they're benchmarking against each other. MedData actually was a pretty strong performer for the last few years. Change was not quite as strong, but didn't do a poor job. And so we've gone through the process. It's important to go through this every few years to make sure we're getting the best service and the best quality for our patients. So an RFP of 9 companies was looked at. 5 different presentations were brought on site, and we have item E, which is Resource Corporation of America, which would be awarded half of the alphabet. Both of these companies cost roughly $1 million a year that JPS would have as an expense.
Okay. Any questions for Rory on either one of these items?
Just one, Rory, I noticed on the measure of success, it says it'll be measured on the number of uninsured accounts converted to government payer reimbursement. Does that calculate how much we pay them, or is that just a success factor?
Well, we actually measure what we convert in terms of payment dollars, and then their fee is associated with those payment dollars.
So it is literally tied to their performance?
Yes.
It's kind of hard too because if they're buying insurance, that we have a chance to collect upfront, but then we get credit for that. Say again.
Can you get your microphone, please?
No, because we have to look at from a perspective that depends on how we do things upstream. Because if they have insurance and we didn't detect it, and they found it to have insurance, we have provision here, we don't pay, they don't get credit, but they do the work also as well, so we have to be very careful with that statement.
As a courtesy to us, when they find insurance, they actually return it to us for billing.
Quick question for you, on, was metadata from M to Z also as well as previous contract, or did we flip it around?
Yeah, I'd have to actually get the actual alpha split for you. I can answer that for you. I don't have it in front of me.
It's to see if we keep them the same or we flip them from A.
Yeah. So I think it's something along the lines of A through L and M through Z, but we could certainly flip that around to see if they happen to perform differently than they performed. Yeah.
So just want to clarify, both of them does more than Medicaid, but they do SSI and SSAI also as well, right?
Absolutely, and there's a skill set there that they have in qualifying those people for SSI that's hard to find. That would be hard for us to grow
But the
internally.
contract does include both sides with.
Yes.
Yeah, there's a process that, you know, certain patients we can screen ourselves through eligibility, but the ones that make it to these two firms are often the more difficult
On the
patients to convert.
metadata one, that's the old Cardin, right?
It's what?
The old Cardin.
I believe it was Change that was tied to Cardin. I can't remember if it was
Change
MedData.
was CEA.
Huh?
Change was CEA.
CEA, okay.
Is the rate stay the same on the metadata?
MedData,
Information on previous years.
MedData held their inpatient rate constant, and then their outpatient rate actually went down 1%.
1%.
So we actually got a favorable pickup there. We'll see that in their rate.
You did a good job with the RCA contract.
Yeah, RCA brought a lot of things to the table from a technology standpoint and how they interface with the patient, online portals, text messaging. Our patients, even though they may need to qualify for a program, they're still savvy with technology. And so RCA brought a lot of things to the table there, as well as favorable rates.
Okay. And does MedData have the capability for texting also?
MedData as well was a notch above on the technology side. They're not quite as advanced as RCA, but they're improving how they interface with the patients as well.
No questions.
Great. Any other questions for Roy? We'll take these items separately. Item 5E, I'll entertain a motion. A motion by Mr. Nguyen, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. Item 5F, motion by Mr. Nguyen, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. Thank you, Rory.
Thank you.
Thank you, Ms. Clark. Pia Walker, item 5G. Good morning.
Good morning, everyone. This morning, what I would like to do is to ask for your approval for the amendment to our current Symphony Talent contract for our mCloud. This is a national resume database and also will assist us with our advertising and recruitment for the organization as well. In looking at this and visiting with Symphony Talent, this is an industry standard best practice to assist us with our recruitment needs for the organization. The cost for this is an additional $120,000 for a one-year contract, which is in our approved budget for FY20. So at this time, I would like to ask for your approval for this amendment.
Any questions for Pia on this item? Motion by Mr. Powell. Reverend Emerson, all in favor, please say aye. Opposed? Motion passes. Thank you, Pia.
Thank you.
Zelia Bama Ball, item H.
Here's to a good recruiting year. Good morning.
Good morning.
I'm here today to ask for your consideration and approval of a contract with Uber Health to provide transportation to our patients all across the district, whether they're inpatient or outpatient. This contract was being awarded because we needed to have a single platform that was a digital platform that would allow us to manage where our patients were going and in what way they were going. And we did go through the RFP process. We received 7 responses. Uber was one of the 7. Of all of the 7, Uber offered the best pricing as well as the best digital platform, and it interfaces extremely well with our Epic EHR, which was also a consideration for us. And this contract is for 3 years. It's an approximate $300,000 cost per year for 3 years to a total of $900,000. And we are really excited with the opportunity to be able to implement this. We think it gives our patients first-class service. And so with that, I'll see if anyone has any questions.
What really caught my attention was the technology aspects to this, allowing us to really track and monitor the usage.
Exactly.
And things like that, which is really great.
That was paramount in our RFP because we have had challenges with that in the past, especially working with a taxi system. There wasn't any a level of accountability with the vouchers. It was difficult to keep up with paper, and so this does allow us, from a management perspective, to be able to have a real good look at where our patients are going, who our patients are that are going, and also probably, definitely from a management perspective.
And we don't restrict it that they can't go to the pharmacy to get their meds and things like that. I mean, we can control that still.
Yes, yes.
But we're not blocking that off. I mean, it's not just to and from the clinic.
Well, actually, in the contract, it states that they can have 1 or more stops on their way home. If it's to the pharmacy or the grocery store, that's included in the contract.
But no, with Uber Eats too?
We did include that in the contract because our patients oftentimes need a way to get to the pharmacy.
Yep.
They may have been prescribed a specific diet, and they need to stop at the grocery store, and many of our patients live in food deserts, and so this allows them that
This
opportunity.
makes sense for everybody.
I have a
Trent,
question
you
for
had a
you.
question?
How do you insure this? Is this an additional insurance right on top of our existing policy? Are we counting on Uber's policy for liability? Where does the liability start and stop on once we turn a patient into an Uber car?
So liability will start when they enter an Uber car, and so in our electronic health record, we're going to have it implemented to where every patient, at least annually, when they ride, they'll have to acknowledge and accept the Uber rights and responsibilities and regulations. And so we'll be able to have that pull up within Epic so that we're able to acknowledge that acceptance on their part.
So if someone gets hurt in an Uber car on the way home,
It's Uber,
that's an Uber obligation?
correct.
Completely absolved.
Yes,
I think your point's well made, Trent, 'cause things happen inside Uber vehicles, we all know.
correct.
We don't wanna
With any
say that
ride
we put
service.
We put that patient in that harm's way because we put that patient in Uber. I think your point's well made.
That's a great point.
But-
I'll let
Yeah.
legal
And-
brief.
And currently, it's no different than when we put them in yellow cab. It's the same thing. It's just a different service.
Is there surge at a certain time too? Or
Excuse me?
The fee, is there a surge at a certain time?
No, it's a
It's
flat
flat.
fee. And it's one of the things that we needed it to have when we looked at the companies that responded to the RFP. We needed an ability to have an immediate transportation option for our emergency room for patients that have been screened and treated and no longer, and they don't need admission, but they don't have a way home. And it's late at night, we don't want them, there's no bus service or anything like that, so that's not the best thing for them, and same for the psych emergency center as well. So there's lots of opportunities to enhance this service for our patients.
I have a question for you, because I asked Uber Health and they couldn't answer me the question when I talked to them a few months ago. Is because most of our population are underserved community, and how do they track that their Uber driver actually cancel?
How do they what?
Because certain area, they may cancel the pickup and stuff like that, like saying no show and all that stuff, so how?
We
how do
would
do
track that.
Okay.
We have the ability within the management of the electronic portal and the platform that we'll be utilizing. So we will be able to track that.
Okay. And do we have internal control on who can use Uber and who can't and all that stuff yet?
Well, interesting you say that. That's a great segue to say stay tuned for February 12th, because I will be presenting the district-wide Uber policy, which has very specific parameters within which we can utilize Uber services, as well as other services that provide transportation for individuals that need medical transport and also may have wheelchair or other issues and they're not able to ride in an Uber ride.
Do we get charged for if the patient throw up in their car and all that stuff? Is there because that's how they get you, is you can't verify if the patient throw it in their car, but they just say they have to clean up and stuff like that. How do we prevent from making
So
sure they're
that
doing
was
it right?
actually part of a consideration when we were reviewing the RFPs. We did notice that there were charges in some of the RFPs for cleaning the vehicle, and that is not in the Uber contract.
So we do potentially have that liability.
No,
I mean,
we don't.
expense.
We don't. It wasn't in the Uber contract as part of the cost, but it was in a few of the other RFPs that we did review.
Okay.
Yeah, there's, some of them said a flat fee of 100, 150, 200, but that was not in the Uber contract.
Is that because they deliberately omit that omission so that they can charge later?
No, sir. I mean, they have to include all costs to us as far as what their charges are with the contract.
Okay.
They can't add another one.
They can't add another one with, and this is a 3-year contract.
And they wouldn't be able to direct bill the patient, correct?
No, not at all.
Yeah. So Alan, average, in looking at this particular contract, are you estimating the number of patients that could be utilizing this service?
We averaged around 30,000 trips annually.
They have special service for Uber Health, or they just the same?
Do they have what?
Special people trained for Uber Health, or they just any car?
They do. There are different trainings for drivers with Uber Health.
Good.
And that's in the contract as well.
Okay, any other questions for Zelia? She obviously doesn't know anything about this, so we. All right, I'll entertain a motion for item 5H. Motion by Mr. Zimmerman, second by Mr. Nguyen. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Zelia.
Thank you all.
Kenny
Yep,
Carr, item
exactly.
I. Good morning.
The Uber policy will not include board members. The board will not be able to use Uber.
Hey, now that you're on to something. Good morning, sir.
Hey, good morning. I'd like to propose for the consideration of the group, this is a contractual agreement between Tarrant County and CareFusion. CareFusion is the company that we actually work with to supply our Pyxis as well as our, and that's for pharmaceuticals as well as supplies. This agreement allows us to upgrade the current software and for about 110 of our cabinets across our system. Increase the security as well as reporting about our PAR levels. And Windows 7, as David told me, is going away, so we need to make this change.
Windows 7's going away? I'm kidding. Any questions for Kenny on this? We have a motion by Ms. DeBose, second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Thank you. Oh, and we have one abstention, Mr. Nguyen. Thank you.
Thank you,
Kenny.
sir. Thank y'all.
Mr. Mendenhall, item J and K. Well, we're kind of a no on this, right? That's.
Or
we're a
no, can I go
on
ahead
this.
and walk away?
Item J, please.
So, yeah, so to follow up on Kenny's, yeah, so if you still have a Windows 7 machine at home or at other businesses that you own, Windows 7 is off of Microsoft support as of this month. So you've gotten your last update that you'll be able to get. So from a district perspective, since Kenny brought it up, I'll talk to you about it. We are at a 97% conversion rate to Windows 10 right now, and we will be done with that conversion by the end of this month. So we're in good shape from that perspective.
Great.
So the first contract that I bring to you this morning for your consideration is a change of our licensing structure that we have with VMware. Now, VMware stands for Virtualization Machine or Virtual Machineware. In our data centers, we use VMware exclusively to run all of our servers. And over the past several years, we've just continued purchasing licensing as we needed it. But these software companies are really no longer doing capital type of purchases. They want to do a subscription-based purchase. And when we looked at our spend level for the next 3 years, or what we're going to be doing in our data center and virtualizing out to the cloud, it's much less expensive for us to go ahead and start our subscription services with VMware as opposed to continually buying capital and burning up capital on these things that we're going to be using for the next 10 to 15 years anyway. So the first one is that contract to move that to a subscription-based with VMware for your consideration.
Any questions for David?
But it has built-in updates and upgrades.
Absolutely. No, thank you for asking that. So many times we get into this push-shove with these software companies where we have to pay $20,000 or $100,000 to do an update when we already own the software. This now is going to come with perpetual updates that we no longer have to pay for those services moving forward. Yes, thank you for asking that question.
Motion by Mr. Petty, second by Mr. Nguyen. All in favor, please say aye. Opposed? Motion passes. Item K.
Great. The next one has two pieces. One is the sole source and of this contract, as well as then secondarily the contract for your consideration. We already own Midas, and Midas does several things for the district. It does adherence to policy. It also does when someone has a fall or something happens in the hospital, it's a reporting mechanism for that. But then also our quality team through Midas PPR, Static PPR, does a lot of quality reporting. And as Dr. Stevenson has been realigning what the objectives of the quality team has been over the last year, we've been working with him over the last year to try to make sure that he can drill into the data that he needs to be able to hold providers accountable to the quality work that they're already doing, but make sure that they can analyze variances and so on and so forth when that's present. So this particular system is something we budgeted for last fall, and we think it's going to make a great difference for him and the quality team moving forward. So I submit that to your consideration.
Any questions for David on this?
What's that? So Conduit is the new company that bought out Midas, right? And so they bought that out, yeah, from Xerox. You got it just a few years ago. Got it.
We have a motion, and the motion has to be two parts. We have an exemption from the bidding rule and then the motion, the amendment itself.
Quick question.
Yes.
Yeah.
Will Midas no longer be Midas, or will it be called something else? Midas is a very common part of our language.
Yeah, so it'll still be called Midas. This is a separate component of Midas. And to your point, Midas has become a verb at JPS and not just a noun. We sometimes hear people saying, please don't Midas me, or those types of things. So it's very interesting there. But that Midas function will still be there. And we're going to have to work with Communication and Community Affairs to rebrand that at some point. But this is a separate component of Midas. Yeah.
Do we have a motion by Mr. Nguyen? And a second by Ms. DeBose. She beat you. She beat you. Yeah. She's closer. You got here quicker. I like her more than I like you. So, all in favor of the motion, please say aye. Aye. Opposed? Motion passes. Item 6, any report from council?
Yeah, for the month of December, there were 26 contracts that were negotiated that were under $500,000, and that report is in your portal.
Okay, any questions for Corey on that? And we have no items in close, therefore we are adjourned. Thank you, everyone.
approval.
Second.
Move for approval by Trent, second by Steve Montgomery. All those in favor signify by saying aye.
Aye.
Those by nay. Nay. Okay. We have a short agenda today, so I probably won't keep you here as long as I did last time. I knew Zim was worried about that. Okay. So, Dr. Duncan, you want to come up and cover the annual incentive plan proposals for 2020?
So before I get started with presenting the annual incentive plan and the LTEP plan, first of all, I wanted to thank members of the board who spent a considerable amount of time, almost a full day, with members of the executive team, those executives that oversee the 5 pillars. Chair Ms. DeBose and Chair of Finance Mr. Montgomery and Dr. Weber spent a half a day with the executives who came in one at a time to present the goal and how they set the metric. There was great discussion that went on. The executive team was well prepared, and I have to say the board members were were also very much prepared. Ms. DeBose really came with a lot of questions, challenged the team, and we came to some great consensus as to how the metric should be set, but more importantly, the why behind the goal. And I think this is often where we lose sight around goals. The importance of goals is really to drive a better patient care for our patients and to do it in the right way. And so I just want to give thanks to the 3 board members who spent the time with us. So with that said, I'm going to present at a high level. I'm going to start with quality. You will see each of the executive sponsors of the pillar approach the table in case there are questions. Our first one, as I said, is our PSI 90. Just to remind the board, this is a patient safety indicator. It is a weighted average of observed to expected for 10 safety indicators. The weights of each indicator is based on the volume of that safety event and the harm associated with that safety event. Last year, under the leadership of Dr. Stevenson, who I have here by my side, and Dr. Hochberg, we did quite well at 0.91. There was a lot of discussion at the last board meeting and also at the session that we had with Ms. DeBose. And we feel comfortable in presenting to the board the threshold, target, and stretch as presented here. Our threshold of 1.0, our target of 0.95. The stretch, as you recall, the last time was at 0.88, and Ms. DeBose asked that we push that stretch out to 0.85.
Okay. Are there any questions on that one?
Go ahead. I want to reel myself in to make sure I understand. The stretch is what? What does the stretch?
Okay, the stretch, when we are setting up the matrix, the stretch means that those are high expectations that you want to move toward.
It's your wildest imagination.
It's a movement toward getting better, okay?
So Reverend Emerson, Reverend Emerson, as you recall, the board has asked us to be consistent in how we set these metrics. And so threshold, we say, is 90% of the time we can reach threshold. 50% of the time we can hit target, and only about 10% of the time can we hit stretch. By moving that out to 0.85, we probably have taken that percentage to even a lower number than 10%.
Explain again why your threshold is 1 and you're already doing better than that today.
Yeah, so prior to this past fiscal year, we had never had in this measure, we had never had a single year where we had done as well as 1.2. Now, let me back up just a half step and explain what these numbers mean. So based upon the types of patients we're seeing, how ill they are, what comorbid conditions they have, their age, the kinds of services that they're receiving, the PSI 90 measure, which is a measure against self, would anticipate that we would get a 1.0. So that means you're performing as would be expected for what you're seeing. If you're above 1, you're performing less well than expected, and if you're below 1, you're better than expected. So this measure is ultimately a very complex ratio of observed over expected. Okay, so anything under 1 is better than expected. I can't tell you for sure that there is a 90% likelihood of us reaching 1.0, because we've only done it better than 1.0 one time. But from a philosophical standpoint, I don't think that it's acceptable for us as an organization to take any credit for providing care to our patients that's not as good as one would expect based on what we're doing. We only want credit if we're either as good as expected or better. That's the only range we ever want to be in ever again. Now, we've only done it once, so I don't know how easy it will be or not to repeat the feat. But you know, this is not a linear measure. You can't go down to 0. There are situations that are picked up by metrics like this that are perfectly appropriate care. And we talked about one, you know, in our session together a few weeks ago, where, you know, someone's shot through the femoral vein. If you fix the femoral vein, if you tie off the femoral vein, you won't get caught for a deep vein thrombosis. You ligated the vein. If you fix the vein, though, the patient won't get a swollen leg, but then the vein will definitely clot later. I mean, it will for sure. I mean, we know it. If you're a trauma surgeon, you know this. So, but then it'll hit us a DVT. But I'm glad we fixed the vein because it's better care for the patient. So you're always going to have a certain number of events that you encounter, some of which are not actually adverse. Okay, it's just the nature of using coding data for a pulled metric. It doesn't get down absolutely to the lowest level, but it is certainly possible, and we proved it last year, to perform better than expected, and we want to keep doing that going forward forever. But you know, if we, you know, have another good year, I could see moving the metrics a little bit lower for the future, but it isn't one of those measures where you can keep going lower and lower and lower and lower, because eventually, you know, there's a certain frequency of stuff that isn't actually adverse that's actually measured by this particular metric. But it does hold us to account for providing care that is at least as good or better than we would expect based on our patient population and the services that we are providing them.
How long ago was it that we hit the 1.2?
So fiscal 18, we were, I think we were at right around 1.2. I think it was 1.2 in fiscal 18, and before that it was higher.
Did we look at what was taking place during that time, or were we able to go back and look at what was taking place at that time to see what maybe those factors that?
We absolutely have, and there are two broad areas. One is that we had to improve care in a whole variety of areas, so we did that. But there were also some opportunities in terms of documentation of comorbid conditions, as well as documentation about some of the events that helped us improve as well. The advantage, you know, to the points, some of the points made in the first meeting, where you saw that case mix index has been on the upswing for some of the, particularly for some of the surgical specialties. A lot of the work here has been capturing more comorbid conditions, so we actually do understand the severity of disease of the patients that we are taking care of better.
There's a lot of factors that go into it, and it really took a lot of team effort to your point, to set up those action plans. We did a lot of the low-hanging fruit last year that I think that helped us move to this 0.91. We now have to really hardwire and sustain the work that we did and continue to move forward with improvements. And so we feel comfortable with the threshold of 1.0. To Dr. Stevenson's point, it is what is expected of us. And our expectation is that we will not be below that we will not be above 1.0 moving forward.
This is last year was our first year we actually measured this. So usually we try to go that next year you'll have a better account. And so I'm thinking one more year, then that would prove that this matrix, which way we should be actually going. Because I do hear what you were saying. And I think a second year that you measure this, then we would be looking at that and saying, okay, you're not going to be able to go back past what your results are. You need to set that as, you know, your threshold. Because I know Zim has mentioned a few things about the optics, but I think on this one, when I looked at it, we went back, talked about it again. This is our first year, so if we go number 2 and then you do better, then we're saying, okay, I know you can't go that other way again, okay? That's kind of how I had to look at this.
So how does this, is there an activity that involves comparing these threshold numbers to a peer group population?
It's tough because, I mean, effectively, we do because the benchmark is 1. I mean, we're comparing to ourselves, but everybody else, but that one number is set by how everybody else performs.
Everybody else being the total population or?
Being other hospitals. Other hospitals. This is a hospital measure.
I think most of those, what we're looking at in this PS1 is in our leapfrog. And so if you are doing well, your leapfrog numbers goes up too. So there are a lot of these overlap. So we are compared to other hospitals because we can see where they are and all of that. So that's our comparative group, and you can pull it out by hospitals in Fort Worth, public hospitals. And so when you read over in the Dallas newspaper that somebody is a B and you are a C, it quickly gets your attention. So that's the other way it ties into that measurement. Okay. Any other discussion on that one? So I agree that we need to go one more year on those to get a better baseline, and then we'll be able to, it'll be a different conversation next year. You agree?
Absolutely.
Because we'll start with where we are. We will not, you know, I just kind of think that a rule that we would be looking at is that you are going to be either starting there. Your target can never be less than what your results were.
Right.
Okay? That's kind of a rule that I would think that we should give some consideration on in setting some standards that you're saying that if we're going to do with results, and if we're not going to go back on results, but your targets can never be less than where you are. That sound reasonable? Okay.
It does.
Well,
Yeah. Zim.
Well, I guess what helps me is if what area we're talking about, if that area is low performing, we start looking at what caused us to be at that low performing position, so we can correct that to bring it up. Okay. But when we perform at the level or above, I don't ever rarely hear what we did to do that. And I just, my thing, and I asked this some time ago, is that I think it would just be healthy if we heard or saw what do we do to get to where we are to achieve that, so that we can either mirror that or apply that throughout the hospital. And it'd be interesting to see what the steps were that got us to that spot. So.
What I would say to that, Reverend, is stay tuned. We have, not for this meeting, but for Quality Committee, we have a lot of very interesting information to share with you in the coming months. And I think that some of those questions will be better answered for you, or at least you'll have more insight to ask those probing questions about how it is that we're actually achieving this. But I was looking at, this is a bit of a aside, but I was looking at some of our core measures data today and just seeing some really remarkable things going on in behavioral health particularly. And, you know, that's something that you're going to want to look at and understand well, because there's some really exciting things going on in that area. So, but this kind of stuff, core measures, benchmark data, that sort of thing is going to come before the Quality Committee on a regular basis in coming months. And I think you'll have some of these questions, have an opportunity to answer some of these questions for yourself, and we'll obviously provide as much insight to that as we can.
Jim?
I understand what Dorothy's saying, and I don't disagree that if you're starting your second year of this kind of a metric, that you probably need to get some more information. But the one up there that really bothers me is the outpatient patient experience, where you attained 8, your target's 4, and so I would question a little bit whether you've got the right measurement parameters set up, and I would suggest to you might ought to go back and look at those to see why you so well exceeded expectations in that one. The rest of them all seem to be in line, and I kind of don't have a problem with that, but that one just glares at me.
So would you like for us to move on to service and we can have some?
Pardon me?
I said, would you like for us to move, we can move on to service and we can explain the outpatient
Sure.
metric and how that
I've
was
made
set.
my point,
Any-
my comments, I'm
Okay.
fine.
No, and I could see looking at that why you would have that question. Any other questions around our quality goal and metric?
Okay.
Thank you, Dr. Stevenson.
Okay, come on,
So-
Laura.
Next one is service. And much like our people pillar, we get our recommendations from NRC, which is our vendor. The first one is our HCAPS. There was a CMS change in dimensions. Last year, we had 10 dimensions. This year, there are 9. The pain dimension was removed. Based upon our previous 3 years of performance improvement, NRC has recommended that we move from what we have traditionally measured as national rate of improvement to striving for the top quartile performance, which is greater than 75th percentile. Again, we use the board's recommendation to look where for our threshold, target, and stretch set. Last year, we did finish at 4. And for next year, for fiscal year 2020, we are recommending threshold of 3, target of 4, and stretch of 6.
On Zim's question, you did some information that you presented. Do you have that? Can we see that? Maybe that would be a better understanding, because the scores actually changed quite a bit from each of those 10 items that we're looking at. It was 8 of them that we only had to do 0.2.
So that was for the outpatient? Yeah, for the HCAPS.
So, I don't have a mic, but for the HCAPS dimension, we can move to outpatient if you wish, but if we can finish on inpatient, I think that might
I
help.
really don't have a problem with the HCAP, it's
Okay.
it's the outpatient one.
Sure, certainly.
Before we move on to the next one, was pain removed because of the opioid crisis? And
Yes.
nothing took its place?
No,
Not today.
We just reduced the scale?
that is correct.
Interesting.
They went from 10 dimensions to 9, and that's nationwide.
Okay. Thanks, that was my only question.
Yes.
All right. Okay.
Any other questions on HCAPS? Okay. Sure. So as far as the outpatient survey itself, we utilize the national industry standard, which today is no longer the CAPS survey, but is what's a real-time survey tool. So when our patients leave the clinic setting, they are issued a survey that is a 10-question survey. We are measuring the same 10 questions that we measured last year. And that is distributed to the patient within 24 hours after the close of their visit. So again, questions are the same. What we did change was last year was the first full year of this particular survey being used nationally. And so our vendor's recommendation was that we move each question 0.3 points. This year, we're in the second year of this survey, and their recommendation, because it's a new survey and it's difficult to get good benchmarking information early on, much like what you just heard with PSI 90 for us, the recommendation was for us to double the improvement rate, so to go from 0.3 to 0.6 improvement per question. And so that would double the number that we needed to achieve. And then again, to Dr. Duncan's point a few moments ago about hardwiring the work that we've done, that can be very challenging when you have a heavy lift like we did last year. So we moved the needle quite a bit last year, and this year it will be about sustaining that improvement and then additionally doubling the improvement rate that we set for last year's targets. The sample size is actually quite large. We will get about close to 100,000 surveys returned on the outpatient side, so it's huge. Yeah, and that's part of the beauty of it, is it's really fast to return to us, so we can action plan on it really quickly, but it additionally allows us a much larger sample size. And we can actually get individual data for it, so we can actually action plan at the physician or provider level.
Checking a particular survey, what's the highest score that can be achieved?
Per question, you mean? It varies. So again, this is top box performance, but the rating scale is somewhat similar to what you see in the HCAHPS dimensions, but also somewhat more complicated. So for instance, the overall rating of provider is the same, 0 through 10 scale. Top box scores, which actually count, would be anything that's rated a 9 or a 10. Anything below a 9 does not count.
So if I understand, I'll ask you a question. Do you expect that your performance in 2020 will be less than 8? Have you got some question about that 8 figure that tells you that it's probably going to come down?
So every time you make improvements like we did last year that are as large as what we did last year, it becomes more and more difficult to continue to achieve at those levels.
I understand that, but when I see a gap between target and the results of 4 points, I kind of wondered, is the criteria wrong? Did we do something miraculous? What was it that caused that big a difference? That difference doesn't exist in any other category up there except that one. So my question to you is, did you go back and question, am I measuring correctly? Are my thresholds and targets too low? And because the whole purpose of this is to incentivize our employees to do better work each year, right?
That's right.
So in outpatient, you're kind of telling me there's nothing better they can do.
No, that is, no, definitely not. There is a lot that we can do.
So my point to you, though, is how is it that that line is going to challenge them to do better?
So the first year, as Laura said, was arbitrarily set at 0.3 rate of improvement for each of the questions. That rate may have been a little low, but it was a rate that we had to start with. We had no previous data. It was new metric across the country. And so that was given to us as a recommendation to improve by 0.3 for each of those 10 questions. So we felt that not only did we do a huge amount of work in community health, but that metric may have been set low. We may have already been out of the gate when that metric was set. For next year, based upon how we achieved, in some of the questions, we actually achieved greater than 0.3. And so for next year, what we said, that we would no longer look at to continue at 0.3 rate of improvement, that we would double that for ourselves. And that's where our challenge would be in going from 0.3 improvement for each of the questions to 0.6 improvement.
So Karen, somewhat, the first set of goals that you set for last year were somewhat peer-placed and somewhat, we think this is about what we ought to be trying to get, right?
Yeah, after speaking with NRC, what was realistic, given that it's the first year that you're rolling this survey out, what is realistic based on our previous performance? And so for us, that may have been too low of a metric. And
So my question to you is, okay, you're into your second year now. In every category, you're probably pretty close to the right quantitative evaluation, except that one. Why didn't we go change that one? Why are we going to wait for another year? And if it's 12, great. If it's 6, you see what I'm saying? We seem to be locked in on these for a 2-year period, when one of them obviously is, we're way over exceeding even the stretch goal.
yeah, stretch.
But you're right. Yeah, I hear what you're saying. This, I don't think we've kind of gone back on this one. We have changed this matrix every year for the last 3 years. We started out using a matrix and remember we had the 72, I have all the notes here. And on that, we're having a hard time achieving, let me say it, we was having a hard time achieving the inpatient. The outpatient have always done a little bit better on their scores. And then we changed to this new survey. And did anybody see this? Did you share this with anybody but me?
So that actually was in your packet last board meeting, and we can get copies of that, to you.
Yeah, that's okay.
If that would be helpful. It was in your last board packet.
Because I can see that, to go back and with you, Zim, where we have made 8. Even on looking at this, with moving it 3 points or 6 points, I'm sure that that's a low score for outpatient, that their numbers could go up some more.
Well, the horse is dead, I'm not going to use it anymore, okay? But as I said the last time, it's an optics thing. And whenever I'm dealing with employees, I don't want to give them an optic that says, oh, okay, I can kind of relax. I want to keep challenging them. And even if it's a fictitious number, when you've made 8, you don't want to go back to 7, do you?
Could you put your stretch at 8? I mean, your stretch should be there. I mean, you can't go any higher than 8.
We could put our stretch today. I think where we set our challenge was that it would no longer be 0.3 every year that we were improving, that we needed to move quicker. And so it was doubling that to 0.6. Next year, if we continue to move along, I think it becomes more and more difficult. The more that we move along, the work becomes a little bit more difficult, but we can do it. That we may have to move to a 1.0 rate of achievement or 2.0 rate of achievement. But I have no problem with putting stretch at 8.
Kind of in my previous business, I'll question the staff on things, but in the end, I rely on you and your expertise to do the right thing, and if you say this is where I want to be for right now, then that's great.
Okay.
Okay, but I don't like the optics at all. I think based on what happened, is there should have been some sort of a modifier that was placed in the data so that we could see actual, let's call it budgeted versus actual. Actual actually came out to be very different than what we thought it would be because it was the first time we'd done the survey, so we see this huge gap. So based on what you know now, if you had to sit here today and project what the score would be at the end of this current year, what would you project it to be?
I mean, where would we
Yep.
end up? That's a hard question to answer because we are high achievers in community health and we always go for stretch. So that is really hard to say.
What would you personally say, this was a good year for us versus, man, we could have done better than that?
I always think we can do better than what we've done. I think it was a good year for us. We put a lot of resource and effort behind last year. And that was representative of the hard work that we did, was that 8.
But you don't believe that's a sustainable number?
If we were to keep the rate of improvement at 0.3, I would tell you that that was sustainable. And we would have moved that threshold target and stretch higher. Given that we're saying that we're going to actually double that rate of improvement for next year, we're not going to just keep it going at 0.3 each year, but that we're going to double that next year, we're going to challenge ourselves, then we felt that the threshold target and stretch as set was achievable and reasonable.
So this metric, let me make sure I understand. This metric is not necessarily measuring the patient's scores of the survey. It's measuring how much we improve from the previous year.
That's exactly right.
Terrible metric.
Year over year.
Because when people see that,
Yeah.
they're not assuming that is representative of a level of improvement over the last year. What they're seeing is that's the score versus last year. If I gave you a 6 last year, and this year I gave you a 4, then it was a worse year, right? So that's how most people look at a metric like this. In our case, what we're actually being asked to consider is how much better are we gonna get? Except when we look at how much better we're gonna get, we're not comparing it to the actual, we're comparing it to how much better we got. And that's a misleading
Because the better you
number.
get, the harder it is to get.
That's
better.
right.
Really
And so
is,
you end
yeah.
up with a bad metric. I mean, to me, the optics on it don't look good, and it doesn't reflect reality. I think the metric from an optics standpoint should reflect, it should show people we're doing better. We're doing better every single year. And when I glance at this, especially for the purposes that we're looking at it, I want to be able to say, look, I can defend, infinitely how much better we're doing based on these numbers without having to stop and explain for an hour and a half why that number's
Why
better
it
than it
is,
is.
Yeah.
Right.
And
Would it be better instead of having the number 8? Because what I'm looking at that y'all don't have, it talks about going from 49.5 up to 56.8. They went from, it's 8 of those. One of them, they started out at 36.6, and they ended up doing 41.9. So it makes sense to me that you would be looking at that increase in those numbers versus saying this 3, 4, because it's the optics, you're right, doesn't look good.
The actual, I mean, if I look at the actual,
Yeah.
and I say, okay, I went from 36 to 45, I'm like, well, that's pretty good. I feel pretty good about that. But in this case, I'm looking at 36 to
Right.
45 as being not good at all because it didn't increase it enough from what the metric was started. And I just think it's a really bad way to show it.
Why don't we say this? He said a little bit better than I did what the concern is. Why don't we task you with going back and taking a look at this, and then either come back with us with kind of what you think needs to be changed or not changed, but with what comments we've made. I don't like to make decisions in a boardroom for the staff, okay? So
Right.
we'll just challenge you, go back and look at this and come back to us.
Okay.
Maybe a different way to illustrate.
and to really show the work, the hard work
Yeah.
that was done.
And
I
then
agree.
maybe y'all would bring a little bit more information when we come to these sessions, showing it a little bit different.
Well, that's
Because we
probably our
did
fault
have,
for not reading our portal last time.
well, I keep my stuff, so, yeah.
I'll be honest about that.
But it is numbers. I mean, we will be dealing with those same numbers, and that might be better than what we had. That's what we started with, Gay. Because I remember Roger was saying, when y'all change, let's make sure we can compare apples to apples. And we have it at the top up here, but we don't show it here.
Yeah, we
So I'll
may
agree
be
with
too
you.
smart. We may have gotten
Right.
too smart
Okay.
in the way that we illustrate.
All right, okay,
Yeah, It's probably
thank
not
you.
apples to apples here,
Right.
as it looks.
Okay.
Yeah. Thank
All
you
right,
for all
thank
of
you.
those comments, and we'll come back with that.
All right.
Our next pillar is people pillar. I have Ms. Walker here with me. We'll start with first-year turnover rate. Reminder to the board that this will be our first year in which we look at the first-year turnover rate. Last year, we looked at overall turnover rate, so this is a new goal and metric for us. Our FY19 result was at 38.67. We feel comfortable with setting our threshold at 32.86, our target at 30.94, and our stretch at 29.01. And a reminder that this metric is set and recommended by national vendor Saratoga. And so there's been conversation with them.
This is all employees?
This is all employees, yes.
No waiting for the end in nursing, for example, being so much higher than the end in administration. I mean, this is just all employees, flat out raw data, overall percentage turnover, right?
Yes.
Yes, so this is all of our employees that are within the first
First
year
year.
of turnover. So when we think about, just as Dr. Duncan has stated, is that we are benchmarking this against Saratoga data, which benchmarks against other healthcare organizations. So we're looking at that first year. And so we have identified, if we focus on that first year of turnover within the organization, it's going to help drive down the overall voluntary turnover as well.
This is voluntary?
This is first year
voluntary.
turnover, yeah, and involuntary. It includes both of those. Yes, because as an organization, we do need to focus on that involuntary because we need to make sure that we're hiring appropriately. Because for us, per policy, we have that 90-day probationary period, and that's something that we do want to make sure that we're leaning far away from it and getting individuals in that's hired right, and so we can be able to decrease that 90-day turnover as well. So that's important because as an organization, what we have to think about, and these stats come from SHRM and they come from Saratoga as our resources. We spend 2 times salary when we deal with turnover. When it gets to leadership, it's 3 times the salary, and then with executives, it's 4 times the salary. So we are spending millions of dollars a year when we're looking at the high percentage of turnover, and that's something that we do need to get under control. What we're going to be doing, looking at that turnover, when we do our LDIs and focus on LAP, we're going to be putting tools in place for leadership to assist them and help them to think about what we can do to help reduce that turnover.
So Pia, is it fair to assume that if I dramatically reduce my first year turnover rate, that equates to a significantly less 5-year turnover rate?
I don't want to assume that a 5-year. I would feel more comfortable to say 2-year. Because now with organizations, what they do, they're not projecting far out to the 5-year mark. When you're looking at healthcare organizations, because healthcare is an ever-changing market, now they like to try to focus on that 2-year piece. So I would feel a lot more comfortable to say that we could look at that probably 2 years later to see how that reduction has looked.
And what would you suggest that at the end, using these numbers, what would you suggest that second year turnover rate might be relative to reductions in this turnover rate?
I think
Is it linear?
it is. I think what we need to look at, again, is thinking about what Saratoga is going to be providing us, and we need to pay close attention to what they're giving us and benchmarking against that number as well. Because we ended the year very high, we set these standards as self over self, and so next year we truly need to focus on where we're in and try to keep pushing harder to focus on what Saratoga is giving us as well.
Okay. Any other questions on that? I have the little Saratoga information up here. I have all your.
Yeah, she
Yeah,
really
'cause
came
there's-
quite prepared, yeah.
But I was looking at their total turnover, that they're targeted, they're saying you should be is about 13.3, based on this report that I have here. First year, they are saying 16.3, 16.3%, so.
So we have a
We
lot of
do.
opportunity.
We do. We
Yes,
have a lot of
do.
work to do.
We do.
Okay, all right.
We'll go on to employee engagement. Just a reminder again that this metric is set by Press Ganey and is based on our previous performance and is benchmarks against similar hospitals. Our FY19 result was at 4.33, and we have set our threshold at 4.31, target at 4.33, and our stretch at 4.35. Any discussion around that one?
I'm with Zim on that one. I'm thinking the threshold shouldn't be less than our actual achievement. You know, I'm thinking at minimum, the threshold expectation should be what we were able to achieve last year, and then move up from that, and not be satisfied potentially meeting threshold and rewarding for going backwards.
Yeah, and I'll let Pia speak to that, but we are, I mean, we result out at a very high percentile. And, you know, staying within that percentile, your score may come down just a little bit, but it keeps you within that top percentile. And I think that that's what's really important for us, is to maintain that top percentile. And so this allows us for a little bit of that slippage, but keeps us in that top percentile.
So,
And I would say, Karen, that argument supports my notion that it should be 4.33 threshold and not 4.31. I mean, it all comes down to how much variation we're willing to accept.
Mhm.
But from an optics standpoint, I would like to be able to say, we've achieved this, we can sustain this, and our expectations are going to be to sustain this from now on. Yeah, let's try to get better. And if we do get better, this is what better looks like. But I don't, in my mind, it's difficult organizationally to accept the notion that we're okay by dropping this 0.2.
Okay. Okay. I mean, I do understand that, because it's hard for me to go from where you are. You always start from where you are, so.
yes, so to speak on that with employee and provider, so Press Ganey is our vendor that we work with each year. When we receive our scores each year at the end of September, top of October, what occurs, we will ask them what is the recommendation that we need to be benchmarking against. So remember, 2 years ahead, we were top decile. This year, we dropped to the 89th percentile, which is expected to occur within organizations, because top decile with any organization is very difficult to hold. Even if you said, Pia, we need to move at 0.02 is very difficult. Trying to move that needle is hard. And so when we go to Press Ganey, we ask them for the recommendation to give to us, because they see all the organizations, they see all the benchmarking. They give to us what other similar organizations, such as JPS, is doing. And so that's how we arrive at our numbers, because you're going to see slippage with your engagement scores, because the reason why you're going to see slippage is because there's going to be changes in organizations. You have to prepare for that change. You have to make sure that you understand that change management is key in organizations. So when that is said, Press Ganey's given that number to us to say, is not saying that we're accepting to do less, but you've got to be prepared for change, because remember, when you're doing an engagement survey, it's based on behavior, it's based on what's occurring in that organization at the time, and you have to set your measures to be able to equate to that.
Okay.
Any other comments?
Provider engagement, again, this metric is set by Press Ganey. I think we will all probably be pleased with this one. Our FY19 result was at 4.02, and we set our threshold above that at 4.08, our target at 4.11, and our stretch at 4.14.
And that represents, that metric represents probably a bigger shift in a 2-year period than any other metric we have in the whole organization. I bet you. Because we used to have numbers that were.
Really?
3.5,
I know.
yeah.
Yeah.
So, you know, that, to me, that's a celebration.
Yeah, that really is. No. Yeah, no, totally agree. Any other question around the people pillar?
Okay.
If not, we're going to bring it. Sharon will join us for the stewardship, and I will let her run through the two metrics that we are proposing, goal metrics.
Good afternoon. I usually say good morning. Okay. So we have not changed the actual metrics for stewardship. They are the same. There is one thing that I want to make sure that you understand. There's really just one of these metrics that are weighted 10%. For most of our employees and staff, it is the modified cost per adjusted admission. If you participate in our long-term incentive, the hospital operating margin is substituted because the modified cost per admission is one of our long-term metrics. So it's either or here for the majority of our employees. It is going to be the modified cost for admission on the AIP at the full 10% weighting. Now, the weighting has decreased this year, and some of the weightings up top have been modified as well. So I don't know if we've talked about that already, but the weightings have changed from last year. So when we look at the stewardship metrics, these numbers, I'm going to start with the budget. The threshold of the $13,991 is set on our budgeted adjusted admissions as well as our budgeted expenses. Now, from our budgeted expenses, the reason that it's a modified cost is because we remove those physician costs from total expense, because in prior discussions, that would be difficult. Some of the physician contracts and coverage agreements, it would be difficult for a director to actually control those expenses in his or her area. So that's where the modified cost comes from. But the $13,991 is based on the approved budget for 2020. As we develop the target number, we assume that volumes are not going to change, but that we're going to be able to save a full 0.5% of expenses. So that calculates out to about $5.2 million in our expense structure, and $13,910 for the target. This year's stretch is a full percentage point reduction in our budgeted expenses, and that would bring the modified cost per adjusted admission to $13,829. I believe last year when we set our threshold, target, and stretch, threshold was budget. Target was a 0.3% savings and stretch was a 0.5% savings. Now we have budget 0.5 and 1%. So this is a more aggressive stretch target. The hospital operating margin, when we set the target and stretch, is using the same savings assumption of the 0.5% and a full percent of those expenses. So those two numbers are tied together mathematically.
What would the 19 result have been modified to the same multiples that we're using for the new report? Because it would have been higher. Just trying to understand how much higher.
So I think for, if you're asking what this spreadsheet would look like if we were looking at the 19 threshold, target, and stretch, what happened is we moved the stretch to the target performance. Now, in our actual result for 19, we were able to carve out $5.4 million from the budgeted expense number, and we took care of a much higher volume. So we had both a denominator impact that was positive and a numerator impact that was positive.
Which, I like that, that's great.
Mhm.
It's a little dangerous when we look at it here, which is not necessarily numerator and denominator. Because when I'm looking at numerator and denominator, it's fair. When I'm not, then it speaks to the fact that, all I gotta do is underdo my budget. In order to move the entire dial for the whole organization and how much money the organization pays out in incentives, all I gotta do is fudge my budget. The city people would never do something like that, but for about 30 years of my life. So where's the protection in that? Because when we use budgeted numbers, and then we had this conversation even earlier today on looking at some of our performance metrics on, the finance report is, what is the real relativity of the budget versus actual? Because if we continually under budget and overachieve, it doesn't point to a good story.
So let me answer maybe about 3 questions.
Sorry, I actually-
That's okay, and I'm going to try to hit those, and then you can tell me if I hit them or not. So the budget process is a very difficult process. People always ask me, oh, this must be a busy time for you. No, my busy time is not year-end. It's not metric setting. It is preparing that budget. We work very closely with operations to make sure that we have the best budget that we can have at the time. I think a couple of years ago, what made this metric relevant for us is that our expenses are fairly predictable. We know that we've budgeted X number of days, and we know how many hours per day an inpatient needs in care at different levels: nursing, staff, care partner, registration, billing. So labor is the big question always, because it's over half of our expenses.
Right.
But where we have those budget items that have a lot of questions is up on the revenue side. I have always budgeted conservatively on the revenue, because the discussion from this morning, you just don't really know what's going to happen in a future formula setting from HHSC. So we do focus a lot on the costs. There was this year, and it's in the detail, but there was this year a $22 million expense budget for onboarding future projects. And the way that we're going to deal with that here is it's not a cushion, it's a control $22 million from my purview. If we release $5 million of that, or $7 million, we'll do 7 because the math's a little easier. If we release $7 million of that, there's $15 million that were not spent. When we use this evaluation, I'll take the total actual expenses and add back the $15 million that we didn't spend. And that takes away that fluff or cushion or padding. And I will say that, each year I go through this calculation with a fine-tooth comb, and we've had discussions about things that probably needed to be adjusted after the fact, and I'm very forthcoming with you on that. So in my mind, the setting of my budget is done under a high level of scrutiny, and I'm not forward thinking on how can I game this metric on an evaluation.
Oh, I know that's not your intent. I'm not saying it is, Sharon, at all. It is not nefarious. I'm not presuming that we intentionally undercut our budget, but I am saying that historically, we always perform budgetary-wise less than actual. I mean, we always budget, in other words, and you can look at performance for the last 10 years in this organization, and in almost every category, we beat budget.
So in 19, we did have a very favorable modified cost per adjusted admission calculation. The year before that, we were just shy of target. So I think, and then, 2 years ago, we used a different metric. We've used district dollars achieved. We've,
FTEs per adjusted patient day.
we did, yes,
And
because it's driving
To me,
50.
that's one of the variables that really ought to be in the calculation, because it excludes the single variable of budget versus actual. And it really puts it down to, once we know what our FTEs per adjusted patient day are, that's real dollars. That is real expense, and it's very measurable. And so I have a little bit difficulty, because I think this particular metric becomes a bit generic and a little obtuse compared to some of the more specific metrics that we know are going to result in savings.
So the FTEs per APD calculation, I would say, is kind of incorporated within here. And that FTE goal is based on a very similar threshold being budgeted, target, and stretch. There's not going to be one perfect metric for the financial goal outside of bottom line, how do we do? But, and that is the trigger. We do make sure we can pay for the plan. But when you try to find one operational goal that is hospital-wide for inpatient, outpatient, ancillary support services, you do kind of come back to this. And it is a industry-recognized calculation, the adjusted and cost per adjusted admission. So I don't know, I hear what you're saying, but I think that the FTE per APD is a much more narrow calculation than this one is.
For sure.
It also does not account for the dollars spent on your budgeted FTEs. We could have a staffing mix change that would cost us more or less, but we're measuring worked hours and paid hours versus what it cost us for those hours. So, kind of really the bottom line is going to be the dollars, and how are we carving out some of those expenses that we incur for patient care across the board. And this is the one all-in calculation.
I mentioned this to Sharon before the meeting, is I'm totally lost in the mathematics here. I don't know what it means, or how you get to it.
So conceptually, it's not intuitive, but it's really not that difficult once you break it down. An adjusted admission converts revenue into an inpatient count. Because our outpatient, inpatients get admitted. And we know our inpatient revenue, we divide that with our admissions. And that might be $25,000 worth of revenue for one inpatient. Then we take our total outpatient, which is pharmacy doses, it could be an MRI of the head, it could be an ED visit, it could be an outpatient surgery. It could span from a couple of dollars to $10,000. We take that average $25,000 in my example, and we divide our total outpatient revenue, and that gives us the dollars, the number of outpatients that produce the same amount as an inpatient case. So that's how we convert outpatient volume to one number and add it to inpatient. So I don't know if I made that better or worse for you.
Well, let me ask it another way.
Surgeons are not intuitive. Okay? Just remember that.
Could we, because we always come back to actual, even though you budgeted last year on budget, we were so much less than budget. So how can we show we are doing better? Because when I look at this, I can't see a positive there. it looks like to me, and this is just saying, when I look at this, it's saying that our modified cost per admission is going to increase somewhere between $800 to $1,025. That's what that says to me. And I don't think in our wildest dream that's going to happen.
We will have an increase.
You
What
will
this
have an
number
increase.
does not show is the associated revenues that might be coming in with those increased initiatives and expenses. So, in the smaller group, we kind of went through what might be accounting for that $1,000 increase. $350 of that increase is related to that $22 million operating improvement fund that we have in the budget for onboarding projects. We have another $310 per adjusted admission for increased salaries for the assumption that we will not be under budget in FTEs per APD, but will actually fill those positions. We added a pretty extensive care management initiative this year. We also had some patient safety. We had markets and merit, so that normalized inflation is included in that 310. The co-location of the data center, the PACS conversion, and some of the presumptive screening, the purchase services went up there, and that's $65 per admission again. And then the rest of them are under $4 million in total, and closer to $60 and under. But there's some really large initiatives that we have in our budget that are driving that increase from 19 to 20.
And we didn't have any of those costs, we didn't have any increases from 18 to 19 and from 17 to 18. Because all I don't understand it. I mean, I understand what you were saying.
Mm-hmm.
It's just that if I'm a constituent looking at this, the optics still doesn't look good.
Our cost per admissions have increased from 17 to 18 to 19. So it may not be the full impact that we have in the 2020 budget, but they do increase every year.
Yeah, we had an increase, and from the first time it was $12,765 to this one, $12,995. So you haven't seen that kind of increase in the actual. That's all I'm saying. I know you're going to have an increase. I just don't think that budgeted increase is going to be that high. And when you compare it to actual, I don't think it's going to be close. That's all I'm saying. It haven't been passed, and so that's how I see it. And Sharon and I have been working on this, and we've been trying to figure out a better way to look at it. And so I hear you, Trent. So
I just don't think it's a qualitative measure. I think it's a quantitative measure. And
Okay.
I think to the extent that we're trying to equate our incentive program to performance, then this is not a qualitative measure. This is a quantitative measure. I think there's better measures that we could use. I'm not thrilled with that measure.
So my challenge, I can't see the impact that we do on the ambulatory side as a system, like the impact and lower the cost of treating the patient, because you're trying to avoid hospital admission as much as possible, because the cost is going up high.
Sure.
And what are other outlets that we can bring the cost down? I just don't see it. Like, for instance, you can't discharge patients, especially behavioral health, if you don't have a place for them to go. So do we keep them here at a high cost, or do we invest in a residential or something? I just don't see how we address the lower the cost by looking at that. So that's my challenge. I only see it going up.
So could I offer that maybe you and I, and we kind of get some information from Trent and them to see if we can come up with more of a measurement that would be better. With that, would you be agreeable to go back and we look at that? And even if it has to separate inpatient from outpatient, some kind of way, so you're doing a good job, but if I look at this, I don't see it. That's all I'm saying. And I would like to be able to have a performance measure that you show that improvement?
So part of any measurement is going to be, at least for threshold in my mind, it has to be based on what was approved in the 2020 budget. We can move forward and use a different metric, or we would, I've got 350 directors that are working towards a 2020 budget that's already been approved, and we've kind of sliced and diced that up so everyone has purview to their budget. If we move threshold off of budget, I would have to go back and replan with each one of those directors and try to make sure that our budget ties back to that threshold in order to have assurance that we would meet it.
Could we just look at, maybe this is not the best measurement for us? Could we just think about another measurement and see if we could look at it that way?
Yes, I can
Your budget is
ask
already
around
done,
and-
not asking you to
yes.
go back and redo budget.
No,
but,
I'm just
yeah.
saying, as we move forward and looking at different metrics, in my mind, a financial metric does have to be tied somehow back to our approved budget. If it's not, then each director may not understand what they have to achieve to get the full organization back to threshold. So I'll have to.
Well, I guess I'll ask it this way. All of these other matrix, those folks have budgets that they've got to stay within and come within too. They aren't going to be able to do what they need to do if they get way out of budget too. So I think budget-wise, I'm okay with knowing we have a budget. But if you have a measurement that if we're going to come back to actual, somehow I kind of need to see something that ties that into the next one. And so I'm with Trent. As I said in the other meeting, I don't know if this is the right measurement. I don't know the right measurement. I'm just having problems with this one.
I realize you can't go back and change threshold. That's static. You can change target.
We can. Now, in our original discussions with the smaller group, we had proposed, similarly to last year, a 0.3% reduction and a 0.5% reduction for stretch. We've increased that reach. So target is 0.5 and stretch is a full percentage now. So we've doubled that expense decrease, and that represents close to $10 million on stretch that we would pull out of expense.
So how does that, so equate that back to the FY19 result, Sharon?
So the 19 result, so for dollar savings, last year was 3 and 5 million. This year it's 5 and 10 million.
So would it make sense to have?
For target stretch.
So is it that you are talking about your savings that you're gonna have?
Yes,
That's
so
3 to
in
5.
order for us to achieve that target that's on the screen and the stretch that's on the screen, respectively, that would be a $5 and a $10 million cost reduction from our budgeted amount, if that's what Trent was asking. Last year, it was closer to a $3 and a $5 million savings for those two
So
numbers.
if you were gonna put your
So we've doubled our stretch from
3
last
to
year.
5 million last year, okay?
Yes.
That's what you said. So your threshold this year is what kind of saving? Would it be?
5 million, it was our stretch goal from last year as a percent. So we have effectively doubled the stretch from last year, and the target this year was the stretch savings last year.
I understand it. I completely get it. I don't think it's the best measure. I think it's too quantitative. I don't think it really gives us a lot of qualitative evidence. I'll go along with it. I just want to say that I think we can do better.
Yes.
Let me say this, probably we on the board weren't as diligent when this was presented to us in the beginning to question what you were doing. So what I'd like to propose is that we accept this as it is, but then make up what it ought to be based on our conversations and what you think, and just set that one aside and dummy that one, okay, to see how it you would have come out otherwise. But I think what I hear you saying, and I tend to agree with, is that ship has sailed for this year, and it would be a lot of work to go back and do something different. So let's not do that, but let's sit down and make up a plan that would have been more optically friendly, and let's track it along with this one during this year.
So at the next HR committee, I can definitely visit with, I might pick DT's brain and see if he has seen a stewardship goal that would be more appropriate. I'll also reach out to a few of my colleagues to see how they measure from a company-wide. And we can have that discussion to start planning for 2021 at the next HR committee. And you may or may not like any of those, and we can go back to the drawing board.
Yeah, I kind of agree with them on this. We're already a third of the way into the fiscal year. And it's going to be at least another month or two before we came up with a new metric. So we would be almost halfway through the year before we gave directors a new direction.
It is.
And
only 10%, right?
And what I'm saying to you is, let's look at
Yes.
parallel to this one that we're not going to use for the incentive plan, but that will give us some data and confidence when we make up next year's as to what our stretches, thresholds, and everything else ought to be. Okay?
I'll have that for you at the next HR committee.
Yeah, it's just one of those things that when you talk about an incentive plan, I've always said the incentive plan should not be so high a mountain that you can't climb it, but also shouldn't be so little a hill that you can get there without any effort. And so somewhere in between there is what you're targeting to do to make sure that everybody is really understanding what their goals are and understanding that it's going to require diligent effort to get there. Okay?
By its very nature, stewardship, if we're measuring financial performance, it's going to be quantitative. I don't know how you get qualitative out of measuring financial performance.
Well, Steve, I don't agree with that. I don't agree with that, because what we're trying to do as a system is we're trying to move this system to overall improve the quality of care for our patients across the board. So everything that ultimately we do, including saving money, ultimately becomes something that we can translate, hopefully, to improved care for our patients.
Absolutely.
So I think when we measure a number against budget, there's a lot of anomalies that occur in budget. And budget is again, historically, budget is the variable to choose, and I get it. But there are, in healthcare, a lot of other metrics that I think do a better job of tying quality performance to quantitative expenditures. And I think we can find those. I just think this one is not, I don't think it's the best one. And if we say next year, this is the best one, then I'll shut up and not say anything else about it. But
You will not.
But I'll go along, I agree with what Zim said.
Okay.
I really do.
You know, we've discussed every single one of these, and the thing that started going through my mind is, are these even appropriate? Should we be still dealing with these pillars, or should we be looking somewhere else for better data? And
I think that, Mr. Chairman, is a very good comment, because it's possible that we as a board need to get back together and really do some hard thinking about our strategies and pillars moving forward, because it's been a while. I think it's a good point, Chuck, I really do.
I think Michael was the one that told me, but I'm not sure, but we've been dealing with these for 10 years.
Yeah.
And healthcare has changed a great
It certainly has.
deal.
Certainly has.
Work that we plan to do over the next year is to bring to you that recommendation, whether these are the right pillars, and it's probably has stimulated a lot of this conversation, because to your point, this may not be the right pillars that we're looking at.
Well, see, I'm gonna speak as sort of
Okay.
chair-elect here.
Go right ahead on.
You elect.
Yeah, wait a minute, chair-elect, you're already elected.
You gonna run again?
Charlie isn't sleeping well yet. But Ralph has mentioned this, other people have mentioned this. I think we need to have, I don't want to say a retreat or pick a term.
I think it's a good term.
But we need to get together as a group and decide where are we going and how we're going to go and how we're going to measure ourselves. That's just,
I think you hear all total agreement in here.
because when all the board members are confused over how we're going to allow employees get some extra money, I mean, I'm lost.
Okay.
And I'm pro-employee, I mean, good Lord, I mean.
Yeah. I think we all are. Okay.
That's the plan, Ralph.
Very tough, because we're moving
Thank
toward
you.
Okay.
transformation of
But now, you're not putting that on my calendar, right? You're not putting that on my- Are you putting that on my agenda?
He's the chairman, he can do anything. Karen, let me make sure you understand.
Here it is, make it so.
I'd like you to look at, there's several things that have now come out on the floor. One is, do we have the right measurements, which is always something you ought to be looking at. But look at your total block as it is and do some adjusting, paper adjustments, not to what you're going to do. And then the second thing is, and when we say have a retreat, most boards have retreats. What a lot of board members don't recognize is when you have a retreat, there's a lot of work staff has to do to support that. So I think before we go schedule a retreat, I think we need to have some more conversation and make sure that we're not going on a wild horse here. But it's clear, I think you're hearing us say, it's time to be more reflective on how we've been doing business and more proactive in how we do it in the future, okay?
We only have 60 days to do that, otherwise they busy with their budgeting for next year.
Yeah, they've already started probably.
I didn't think he was saying that, what I understood is we were gonna keep these measurements for now.
Let's move
And
on.
then we'll move on this, but at the same time, we're gonna be looking at what we're doing. Is that not what you heard us say?
I thought that's what I heard you say, but
Okay.
I'm not gonna put words in your mouth. But to DT's point, Karen and I have had some high-level conversations, but, the overall goal, and it's taken us a few years to perfect this, would be as soon as we get these 2020 goals approved, then immediately begin to work on the 2021, because
Right.
probably around the May timeframe is when we would be layering on any budget initiatives and expenses. That would be the moment that we could really be impactful with goals and visions and how we could start to redirect some of those budgetary funds along with the facility plan. So it's all kind of gonna have to come together in the next 3 to 4 months, and it will, but understood and that your comments I've taken to heart, and I will be trying to find some better metrics or alternatives that we can discuss, and I'll bring several. And, but it is the stewardship for me is very difficult when you look at how the plan is impactful across the organization, to really focus on, what every person can do and still be impactful to reaching this goal.
Okay.
Yeah.
All right. Are we done with that one? Okay, all right.
If you're
Okay,
done.
thank you, Sharon. And so next is the physician proposal, which is only one change. Sharon? I mean, Dr. Karen? Sharon and Karen, y'all get me confused here.
Karen's still here.
Okay,
So the annual incentive plan for, I guess this is for the physician executive.
Yeah.
This was, conversation around this, again, these are the same goals and metrics that we just previously discussed and went through. The only subtraction off of this as compared to the overall annual incentive plan is the stewardship pillar, and there was discussion around that last time as to why that would not be
And whatever recommendations we've made on the other program that concerning the service, you'll come back on that for this group. Remember, we took the stewardship off of the physicians because of the start, that we didn't want that. So we're okay with this?
And we moved the 10%
Mhm.
to the other one.
We got it in the
We
quality
moved it
service
into the
and people.
quality, yes.
Okay.
Moved it across.
Okay.
Any-
Everyone comfortable with that one?
Any
Okay.
question on that one? Okay, great.
All right.
Our next one is our LTIP, proposed LTIP. This has not changed from our previous FY 2019. Continues for quality to be the Leapfrog Hospital Safety Score and our cost per adjusted patient admission.
Okay.
Any questions around that?
All right.
For those 3 physician executives who are credentialed here at the hospital, again, the same conversation around the Stark law applied to this one. So we will continue with quality, the Leapfrog Hospital Safety Score. And what was added here is physician alignment. This is different than our physician engagement. Physician engagement is much like our employee engagement, which reflects the work environment. So how well they feel supported, would they recommend the hospital? Questions that are very much like those that we take our employees through. Alignment speaks to really the collaboration and the communication between your physicians and your leadership, whether that be your physician executive leadership or other executive leadership. Those questions are a little bit different. Some questions that come through that survey include, I have adequate input into decisions that affect how I practice medicine. I can easily communicate any ideals or concerns that I may have to the executive leadership team. Executive leadership team is responsive to feedback from providers, and I have confidence in the executive team's leadership. So that's just an example of those questions that differ from the engagement.
What was your sample size on that one, Karen?
Pia? How many providers took the survey?
The participation rate was 70.
Yeah, I don't know what the absolute.
I got it.
Yeah, which was really good, very
Go
good.
through my
The
page.
previous year was below 30%, so considerable improvement. So we feel that both of those are important. It's not only engagement, also how well they align as we work with our claim physician group.
Okay. Any questions or anything on that? Okay. All right. So we need this. Now that we've had our full discussion on that with the recommendations, I will need a motion to approve with the recommendations, okay?
Move to approve with recommendation.
All right.
Second.
All right, is moved by Zim, second by Chuck. All those in favor signify by saying aye.
Aye.
Any nays? Okay.
Thank you.
Staff said nay.
Thank you.
Okay. All right. So now that will conclude our open meeting. We need to go into closed session. So now,
Let's do this one.
we've done this one.
They're separate.
Oh, okay. Wait a minute. So you're saying I need to do the annual and the long-term as separate? Okay, I'm sorry. Okay. Okay, we just approved the annual incentive plan goal. Now we need a motion to approve the long-term incentive goal plans with recommendations. Okay. Zim, Roger. Okay, all those in favor signify by saying aye. All right. Now, we will need to close to go into closed session. And we don't need but about a 5-minute break, gang. It shouldn't be long, I swear. I said this one would be long.
Don't jinx it.
Thank you. That was a good discussion.